Welcome back to Healthy Living, brought to you by St. Tammany Health System. I'm your host, Melissa Hodgson, and we're talking today about cardiology. We visited first with Dr. Reed, and he taught us a bit about primary care and initial workups in cardiology. Next, we'll talk about some interventional options with Dr. Paul Stahls. Dr. Stahls, welcome to the show.
Thank you for having me.
Really glad to have you here talking about heart health and heart disease. Let's start maybe with just your background. Tell us about how you came to be in cardiology.
I think that's best answered by my youth as a athlete, and I recall being on the clinical rounds in med school and just being absolutely drawn to cardiology. Undeniably, I couldn't find myself interested as much in any other field, because I remember what got me up off the field and off the mat all those years of playing sports, and it was the heart, and it was the incredible strength of the pump and of a normal functioning pump to keep me rolling and doing things. And if you look around, that's really the incredible story of human existence, is that there's a single normal heartbeat, considering the embryology and the formation of the heart, and it's just amazing to me.
And I agree with that. I think when you realize that every human being, there is a normal heart rhythm to a normal human being, and we're going to try to keep people healthy and recognize what that range is, I think it's fascinating. And you learn about that in your training, and you start off, as you said, in medical school, and then you choose a specialty and you go into cardiology, and you further specialized into something called electrophysiology. So can you talk a little bit about what that is?
Electrophysiology is a field that didn't exist when you and I were born, and it was a weird offshoot sub-room meeting at the American College of Cardiology for many years, and then a lot of guys, really smart guys and gals, researchers and folks that were interested in the electrical activity of the heart. And look, that interest began 150, 160 years ago, and the first EKG machine was about the size of this room, with a guy sitting with his foot in a bucket of salt water and getting one single heartbeat etched on a piece of smoked glass at a time, and identifying that there were detectable electrical signals that were derived from biochemical processes. Now, I don't want to get too technical, but that's, I suppose, part of the elegance and incredible nature of the heartbeat that I am referring to, is that every single heartbeat is a series of cellular activities. And there's a lot that we can do to continue to make normal rhythm and normal function, but there's a lot that can go wrong with that. And when it goes wrong, assessment of how those rhythms and arrhythmias are occurring and what they mean clinically is what I specialize in.
And you just used a word that we toss around in cardiology and heart care, arrhythmia. And even people who are faced with that learn to say that word. But if we break it down, what we're talking about is irregular rhythm. And so arrhythmia is part of what we're correcting, right? And so electrophysiology is one of the things that you can do, but there are lots of procedures that you can talk about that patients may benefit from if they have arrhythmia, or we say AFib, which is another short-term or shorthand that we use in the medical industry, and people learn to say, but they don't necessarily understand. So can you talk a little bit about some of those procedures?
Certainly. And I guess first, to talk about the arrhythmias themselves, there's a variety of them. A number of them arise from the top chambers. Some are because of extra wires that you're born with, and that's a very common phrase you'll come across, specifically with young, healthy people, called supraventricular tachycardia. That's commonly, 9 out of 10 times, going to be because of 1 or 2 extra wires that you were born with when you formed in your mama's belly. And those are, I don't want to say easy to fix, but those can be things that we absolutely fix, and fix once and you should never have again. Then there's other arrhythmias that develop over time, and these kind of abnormalities can develop when you're a small child or a teenager, which are more rare and less common. And those, in fact, I put a pacemaker in a young lady who was 28 years old a couple of months ago because her heart would just stop. But now she's not passing out, and she really has a whole new lease on life. So there's a variety, and then within each of those varietous problems are a spectrum of abnormalities. And perhaps the most common is when we talk about the dysfunction of the middle-aged and older age patients. And we see a lot of dysfunction at different parts of the conduction system of the heart. And when we talk about them being wires or electricity, understand it's at the cellular level that we're thinking, and even sometimes the biochemical. So as it pertains to procedures, there's a variety. And if there's dysfunction of the conduction system where it pauses or doesn't work right, then we have pacemakers and defibrillators and devices that we can implant inside the heart that will maintain a heartbeat and not allow you to go for longer than we program that device to say, standardly 60 beats a minute. And so that's where pacemakers come into play, right? They're just wires that sit in the top and bottom chamber of the heart, sometimes with extra leads to provide different kinds of therapy. And those make sure you don't go too slow. Defibrillators are pacemakers that then can also treat bad rhythms that can kill you. And those typically arise when your heart has gotten sick from something else like cardiomyopathy. And that can be either from blockages or from infection or infiltrative disease. So defibrillator therapy, pacemaker therapy, that's a whole set of what we call device therapy. And the neat part there is those devices are shrinking. I've begun to put in a small device that's a pacemaker. It's about the size of a vitamin that you just implant in the right ventricle with no leads. And they're developing small pills, if you will, that are going to go in the top chamber of the heart and probably even off into the left ventricle. And we're going to be pacing folks with small little devices that don't even have wires. So we're in an evolution, and that's one of the most incredible parts of my field, is there is a constant technologic evolution as things shrink and become smaller in regards to the microprocessors, et cetera. Then when it comes to the arrhythmias that are fast, and atrial fibrillation being the most common one of which, there are the ablative processes that we can put people through. And what I do is go in through the veins, typically from the groin, because it heads back into the right side of the heart, and then from the inside of the heart with small catheters and small electrodes on those catheters, we can detect exactly where the arrhythmia is coming from, or spinning or arising, and then try to address it with ablative therapy.
Wow. So it's amazing to me that you're thinking about how electricity exists in our bodies and keeps us running, and everything that you do has to do with understanding whether those beats and those signals are too fast, too slow, pumping the blood where it needs to go, and that you are able to intervene in ways that are either non-invasive or minimally invasive to regulate the heartbeat and keep everything running smooth.
Yeah, and in our atrial fibrillation ablation, again, probably is the most common arrhythmia, and therefore demands the most ablative attention. Those therapies are evolving, and we're even evolving our understanding of exactly what's happening for them to arise. And so the interesting part is the neuroelectrophysiology, if you will allow a term, because of the innervation of the heart, where the neural ganglia and the innervation of the heart occurs, is going to be part of how we target therapy in the future. And what we can do is a stepwise progression of ablations to manage that. But unfortunately, despite that programmed approach and understanding of certain things that we're doing to block signals from entering the heart, sometimes we still don't conquer it or beat it, if you will, and that provides a lot of clinical challenge. We do have medicines that help us, and it can just be a very frustrating process. So that's when patients hear me talk about what we're going to do an ablation, they think, oh, great, check and done. Well, I envy my orthopedic friends, and they may give me a hard time for saying this, that you have a broken bone, they fix the bone is not broken. Well, that's not quite as simple as how we are working inside of the heart, because of the complexity of some of these arrhythmias and the level of disease. And Dr. Reed, I think, referred nicely to a lot of the risk factors. And I think if you think about what are the risk factors and what creates the substrate for this disease that we're referring to of arrhythmias, it is so inherently tied to basics of good diet, exercise, and weight loss. And I say that because I say that a lot to a lot of patients. Sleep apnea is a huge impact on the heart, and it's because of not allowing the heart to rest properly and large doses of adrenaline that cause, at the biochemical level, abnormalities. Beyond it, obesity, as much as we may culturally accept it here in Louisiana and Mississippi particularly, is absolutely a physiologic challenge. And so hypertension, obesity, sleep apnea, smoking, for gosh sake, I mean, the occasional cigar maybe, but 1, 2, 3 packs a day is just, it's got to be, in modern parlance, unacceptable. And we've got to move past that as a habit. In fact, we ought to make a pack of cigarettes $50 a pack, if you ask me. But those things are so impactful on the human body, and it sets up, it's really a matter of a battle of attrition in life. And the way I challenge my patients is to say, at 45, you need to be planning for 55, 65, and 75. And if you don't set the table, you're going to have a different version of that 55, 65, 75 than you anticipated. So you have to put in the time early, and you have to mind these kinds of risk factors and really stay on top of things. So having a very active lifestyle, keeping the weight down, eating a good diet. I say this, and we'll keep it direct. If you're seeing something advertised on TV to eat, you probably shouldn't eat it.
Okay. Excellent advice, Dr. Stahls. Thank you so much for coming in.
Yes, ma'am. Thanks for having me.
You're watching Healthy Living, brought to you by St. Tammany Health System. I'm your host, Melissa Hodgson. We're talking today about heart health and heart disease. We've met with Dr. Reed and Dr. Stahls, and up next, we'll meet Dr. Antoon. We'll be right back.